Welcome to this high-yield explainer. Look, if you're a focused learner hunting for that ultimate exam survival guide to absolutely crush your specialty boards, you are in exactly the right place. Today, we're going to master the pathophysiology, those incredibly tricky diagnostic traps, and the strict treatment protocols of cryptococcosis. Because, listen, this isn't just about memorizing a list of dry facts, right? It's about truly understanding the why behind the clinical guidelines. That way, when you're staring down a convoluted paragraph-long patient vignette, the correct answer is just going to jump right out at you.
Okay, let's dive right into this. To keep your mental map clear and avoid any cognitive overload, we've broken things down into 4 distinct sections. First, we'll meet the pathogen. Second, navigating diagnostic pitfalls. Third, the 3 treatment phases. And finally, contraindications and exam traps. All right, part 1. Meet the pathogen. Unmasking Cryptococcus.
We have to talk about this absolutely devious strategy it uses, known as the Trojan horse mechanism. It's essentially a biological heist. Here's what happens. The host macrophages swallow the Cryptococcus yeast, right? But they failed to actually kill it. Instead, the yeast just survives, perfectly happy inside the macrophage. That macrophage then travels through the bloodstream, sneaks right past the blood-brain barrier, and unwittingly delivers the living pathogen straight into the central nervous system. It's fascinating, and it perfectly explains the pathogen's deadly tropism for the brain and spinal cord. Plus, it tells us exactly why it manages to cause such severe disease with remarkably minimal inflammatory response in the surrounding tissue.
And this brilliantly illustrates the crucial differences between the 2 main species complexes you are definitely going to be tested on, Cryptococcus neoformans and Cryptococcus gattii. Let's anchor these in your memory right now. Neoformans, think pigeons. It's found worldwide in pigeon droppings, and it's an opportunistic predator. It predominantly preys on the immunocompromised, specifically AIDS patients with a CD4 count below 200 or folks on heavy glucocorticoids. But then we have C. gattii. For this one, think of the 1999 Vancouver outbreak and the Pacific Northwest. Its reservoir isn't bird feces, it's eucalyptus trees and other arboreal species. But here is the highest yield fact you need to know. C. gattii frequently attacks immunocompetent hosts. These patients often have these hidden autoantibodies to GM-CSF. That impairs their macrophage function just enough to let the yeast take hold, and it frequently forms these really large granulomatous masses called cryptococcomas. Moving right along to part 2, navigating diagnostic pitfalls, CRAG, India Inc., and CSF. So, you do a lumbar puncture. How do you actually confirm the diagnosis? Well, there's a strict hierarchy to our diagnostic tools here. India Inc. is your rapid test. It's a quick visual of the yeast's capsule, popping up as a clear halo against a dark background. But honestly, its sensitivity is only about 50 to 80% in AIDS patients, so it's not foolproof. Next up, we have CRAG, the cryptococcal antigen test. This detects the polysaccharide capsule itself. This is your heavy hitter. It's the most sensitive and specific test for CNS disease in both serum and CSF. And finally, fungal culture from CSF or blood gives you that ultimate definitive diagnosis. But wait, here is your first major trap. Now, what's really interesting about this is that while CRAG is the absolute best test for initial diagnosis, you must never, ever use it to monitor the patient's response to therapy. Why? Because that polysaccharide antigen clears out of the body incredibly slowly. The test is going to stay positive long after the actual fungal cultures have completely cleared. So don't fall for that on test day. All right, let's put our test maker hats on for a second. Imagine you get a CSF panel back for a confirmed cryptococcal meningitis patient, and the white blood cell count is tiny, less than 2 per microliter. Basically, 0 pleocytosis. Why is this very low cell count a paradoxically terrible sign for the patient's prognosis? Well, think back to the pathophysiology we just covered. If there are no white blood cells rushing into the CSF, it means the host is mounting absolutely 0 immune response. That massive capsule and the patient's compromised immune system have essentially paralyzed the body's defenses. No cells means no fight. And unfortunately, that correlates with a significantly higher mortality rate.
Okay, we've got our diagnosis, so let's hit part 3. The 3 treatment phases, a strict timeline.
You need to know this timeline cold. The standard treatment for CNS cryptococcosis strictly follows the rule of 3. Step 1, induction. The goal here is rapid, and I mean rapid, reduction of the fungal burden in the CSF. You have to use a synergistic combination of IV liposomal amphotericin B and oral flucytosine, which you'll often see written as 5-FC. This phase lasts for a minimum of 2 weeks. Now, why the combo? Because if you try using 5-FC as a monotherapy, it leads to rapid, predictable drug resistance. You absolutely always combine it with amphotericin B. Step 2, consolidation. Once induction clears the bulk of the infection, you switch over to high-dose oral fluconazole. We're talking 400 to 800 milligrams a day for exactly 8 weeks. Step 3, maintenance, also known as suppression. The patient steps down to a lower dose of fluconazole, about 200 to 400 milligrams a day, for at least 1 full year. And keep in mind, if the patient has AIDS, they are staying on this maintenance therapy for life, unless their CD4 count successfully recovers to above 100 or 200 while on antiretroviral therapy.
Now for the really juicy stuff, the things examiners love to test. Part 4, contraindications and exam traps, the do not list. I'm going to fire these clinical alarms off one by one, so listen closely. First trap, do not prescribe echinocandins. Cryptococcus has inherent resistance to this entire class of antifungals because of its unique cell wall structure. They are literally completely ineffective. Second trap, managing elevated intracranial pressure. You are going to see options for mannitol or acetazolamide, just like you would for other causes of high ICP. Do not pick them. Neither drug works for Cryptococcosis-induced pressure. The only correct way to manage this is the physical removal of the fluid. You do that via serial therapeutic lumbar punctures or by placing a VP shunt. Third trap. If your patient has HIV, do not start their antiretroviral therapy immediately. You have to delay ART for 4 to 6 weeks after you start the antifungal treatment. If you jump the gun and start it too early, you trigger a massive immune system reboot. That leads to immune reconstitution inflammatory syndrome, or IRIS, which will dramatically worsen the CNS inflammation and can absolutely kill the patient. And there's one more. So the crucial point here is, in typical bacterial meningitis, we throw glucocorticoids at the patient all the time to bring down inflammation, right? But in HIV-related cryptococcal meningitis, prophylactic dexamethasone is strictly contraindicated. The research is crystal clear on this. Steroids reduce fungal clearance from the CSF and actively increased patient mortality. It's a classic red herring on exams. Do not fall for the steroid trap. All right, we've unmasked the pathogen, navigated the diagnostics, locked down the treatments, and dodged the traps. Let's bring this whole shebang together with one final provocative thought to test your synthesis. Imagine an immunocompetent patient from the Pacific Northwest presents with a large granulomatous mass in their brain, a cryptococoma. Which specific species complex and what hidden immune autoantibody are most likely responsible? If you said Cryptococcus gaudy and an autoantibody against GM-CSF, boom, you are perfectly primed for your boards. You now have the exact mental scaffolding you need to navigate this complex, high-yield topic. Keep this structure fresh in your mind, stay sharp on those diagnostic and treatment traps, and you're going to handle these clinical questions with absolute confidence. Thanks for joining me for this explainer, and happy studying.